This is diabetic ketoacidosis, an intensive care level metabolic emergency where dehydration, acidosis, and potassium shifts can become rapidly life-threatening. Initial actions. Transfer or admit the patient to the intensive care unit immediately. Start oxygen, place pulse oximetry, establish intravenous access, and begin continuous cardiac monitoring. Get an electrocardiogram early because potassium abnormalities can trigger dangerous arrhythmias. As you're getting the patient stabilized, don't forget the physical exam and monitoring. Perform a focused general, cardiovascular, pulmonary, and abdominal exam. Watch for dehydration, altered mental status, and Kussmaul respirations. Begin strict monitoring right away, with hourly fingerstick glucose checks, continuous cardiac monitoring, and frequent vital signs. At the same time, you'll want to begin your diagnostic workup. Send core labs including complete blood count, comprehensive metabolic panel, potassium, magnesium, and phosphate levels. For the ketoacidosis workup, check serum ketones or beta-hydroxybutyrate and calculate the anion gap. Your analysis is important, and always order beta-HCG in females with abdominal pain. Arterial blood gas and hemoglobin, A1C, are optional, but very high yield. The diagnostic triad is hyperglycemia, an ion gap metabolic acidosis, and ketones. Once the diagnosis is clear, treatment follows a very specific sequence. The sequence matters. First, start aggressive intravenous normal saline. Before giving insulin, check potassium. If potassium is dangerously low, replace it first. Once potassium is safe, start intravenous regular insulin. Continue electrolyte replacement as needed because insulin can rapidly worsen hypokalemia. Monitor the anion gap closely because closure of the gap, not just glucose normalization, is the best marker of resolution. As treatment continues and the glucose begins to come down, the next phase becomes important. Once glucose drops to around the 200 range, add dextrose while continuing insulin to avoid hypoglycemia and continue clearing ketones. When the anion gap closes, transition to subcutaneous basal insulin, such as glargine. At that point, you're mainly focused on ensuring the patient is metabolically stable and ready for discharge planning. The patient remains in the intensive care unit until metabolically stable. Before discharge, provide diabetes education and counseling. Do not forget preventive care when appropriate. Before we finish, let's quickly review the most common CCS mistakes. Always check potassium before insulin. Do not forget intensive care admission, magnesium and phosphate levels, or beta-HCG in females. And remember, the end point is closure of the anion gap, not just lower glucose. If you remember one thing, diabetic ketoacidosis means intensive care, fluids first, potassium before insulin, hourly glucose checks, and treatment continues until the anion gap closes. Thanks for listening. If this review helped simplify a difficult topic, consider subscribing for more high-yield medical education content, and let me know in the comments what topic you'd like covered next. Until next time, keep learning, keep growing, and keep expanding your horizons.